Hi everyone, we're OBGYN residents at UC Davis.
The goal of this video is to aid the obstetrician in assessing and managing a deeply impacted fetal head.
We are going to summarize and demonstrate various techniques that providers can use to safely and successfully deliver in these complicated situations.
A deeply impacted fetal head can be defined as the inability to gently elevate the head out of the pelvis on vaginal examination. This can also be encountered during cesarean section when there is insufficient space for the surgeon's hand between the pubic symphysis and the fetal head to facilitate delivery.
Delivery of the deeply engaged head can be technically challenging and associated with significant complications for both the mother and the fetus. Maternal complications include major hemorrhage, longer hospital stay, greater risk of bladder trauma, and extensions of the uterine angle, potentially leading to broad ligament hematomas. Fetal complications include hypoxia resulting from prolonged time to delivery and direct trauma.
Let's discuss when you might encounter a deeply impacted fetal head. Common scenarios include a prolonged second stage of labor and failed operative vaginal delivery. Pelvic anatomy can also play a role, particularly non-gynecoid pelvises, such as the platypoid pelvis, are at increased risk of deeply impacted head and persistent OT position.
There are many techniques which can be used to disengage the fetal head in these situations. These can be divided into push and pull methods. In this video, we will be demonstrating the pull methods, which do not require any additional instrumentation. These are the reverse breech extraction and the Padwarden maneuver, also known as the shoulder first method.
First, we will demonstrate the reverse breech extraction. This maneuver is particularly helpful for babies in occiput posterior or occiput transverse position. When initial attempts at elevating the fetal head are unsuccessful, reach up towards the fundus and grasp the fetal feet and ankles. With steady traction, pull the feet towards the hysterotomy. The fetal rump should follow. At this point, the maneuvers will be similar to a traditional breech cesarean delivery. Once the fetus is delivered to the level of the scapula, rotate the baby to one side and sweep the arm anteriorly across the chest. Finally, the head is delivered via the Mariceau-Smellie-Veit maneuver.
This town's so lame, I'm feeling so wired. It's 4 a.m., I'm not even tired. We're in your car, we can drive away. Oh yeah. We're almost there, I'm loving this feeling of something new. Just right what I needed, take me there. We can drive away. Oh yeah. Listen to the midnight radio.
Next, we are going to discuss the Padwarden maneuver. First, let's review a little history. This technique was first described by Doctors Padwarden and Modasha from the Wadia Hospital in Mumbai. It was initially published in the Journal of Obstetrics and Gynecology of India in 1957. Now we will demonstrate their maneuver. The Padwarden maneuver is typically best for babies in occiput anterior position. You can suspect a deeply impacted fetal head when a shoulder presents after performing the hysterotomy. Identify the presenting shoulder and attempt delivery of that arm. Next, gently rotate the baby in order to deliver the opposite arm. Once both arms are delivered, Reach up towards the uterine fundus to gently grasp the fetal rump. Have your assistant apply fundal pressure for delivery of the rump, the legs, and the feet. The remainder of the body will be rolled towards the hysterotomy, and the fetal head should easily follow, being mindful of overextension of the fetal neck.
Listen to the midnight radio. Listen to the midnight radio. We can drive through the night, sing along to the midnight radio. Don't wanna wait all my life, can't remain no delay.
Thanks so much for watching this video. We hope you learned something.